My name is Eric Jensen. I'm a professor at the University of Minnesota and the chief of the Division of Surgical Oncology. And today we're going to be talking about liver-directed therapy for metastatic and colon and rectal cancers. I do have one important disclosure, and that is that I am a consultant for Jensen, the big medical firm. And I'm a consultant essentially as a teacher for other surgeons in this country and abroad. And I do teach minimally invasive liver surgery. Most specifically, I teach other surgeons how to perform ablation, and I sometimes do receive compensation for that. The objectives today, we're going to talk about some cases of metastatic colon and rectal cancer. We're going to review the evidence supporting the role of surgery for the treatment of metastatic disease. We're going to discuss options for surgical approach, and we're going to discuss some of the most current and future paradigms for liver-directed surgical therapies. This slide shows a lot of old data, but there really aren't any more modern data because this is established at this point. So these are some of the sort of sentinel trials, or reports anyway, for liver-directed surgery for colorectal liver mets. And basically, if you focus on the 5-year survival, that's probably the most important part of this slide. And what you can see is patients who have metastatic colon and rectal cancer to their liver with surgical resection can have 5-year survivals anywhere between 25 and 60%. And if you look at a similar time frame for patients receiving chemotherapy alone, the expected survival would be more in the sort of 10 or 15% range. So surgery clearly has a role in extending the survival for patients with metastatic colon and rectal cancers. So these trials were the basis, or these reports were the basis of why we really started doing more and more liver resections for metastatic cancers. And probably the most notable of all of these is the one by Dr. Fong, the third one down there. So we'll just touch on that a bit more. In 1999, the group at Memorial Sloan Kettering, led at that time by Yuman Fong, they reported their outcomes with 1,001 patients that had had metastacectomy for metastatic colon and rectal cancers. And essentially, they came up with this prognostic scoring system, which is now called the Fong score. You can actually get it online. If you type in Fong score, you'll find it, and you can type in these criteria. And it will basically give you an estimate of the 5-year survival. And the factors that were identified all the way back in 1999 have been essentially validated over the last couple of decades, and they have still proven to be the most effective scoring system for patients with metastatic disease. And the 5 criteria that it really comes down to are whether the primary tumor had lymph node positivity, whether the disease-free interval was less than 12 months, whether they have a tumor that's larger than 5 centimeters in their liver or more than one tumor in their liver, and a CEA level of greater than 200. And you can see the panel on the right shows that as you increase the score, those things diminish survival. So best case scenario, a patient with a small tumor, distant from their original cancer, all good features, has a 5-year survival of about 60%, while a patient who's in the worst case scenario is going to be closer to 15%. And actually, that gets closer to what can be expected with systemic chemotherapy alone. So patients that have high Fong scores, we definitely have to be very selective about who we're going to operate on versus who should be on systemic therapy. So I'll just give an example to demonstrate this. This is a patient who had metastases, so a 65-year-old guy who had a colon cancer in the past. His original colon cancer was node negative. He now has an MRI that shows this lesion in his liver. The lesion is small, it's less than 5 centimeters. His cancer was over a year ago. It was a node negative primary, and his CEA is low. So this is a patient, just showing his PET scan here, the area of uptake there. This is a patient that in the past we would perform a liver resection. And so this is just a picture showing we essentially did a central hepatectomy for this particular patient. And based on the Fong score, he would have an estimated 5-year survival of about 60%, which is certainly significantly better than palliative chemotherapy alone. So in addition to resection, what other liver-directed therapies do we have? And the list is growing essentially constantly. I'm going to show another example first to demonstrate why we need other techniques. And this is a 35-year-old gentleman, male patient who presented with rectal bleeding. And this is the scout film of his PET scan. The PET scan basically showed that he had a large tumor in his rectum, but also in his liver. He had a tumor essentially replacing the left lobe, and then several additional lesions in the right lobe. This is a patient that would not be a candidate for surgical resection because he simply would not have enough liver left in his body if we were to do that. These images on the right are his MRI images, just showing the same thing with a large tumor in the left lobe of the liver and then several additional tumors in the right. So this is a patient we would treat a little bit differently than that first patient. This patient received upfront chemotherapy, and then he had a left hepatectomy along with microwave ablation ×4 for the lesions on the right side of his liver, along with a low anterior resection with colon and rectal surgery. So what is microwave ablation? Some of you may not be familiar, but microwave ablation is essentially a technology that uses the same energy as your microwave at home. There's a picture of the machine on the left of your screen there. It's a very simple device that we literally just set the power and the time we want to burn. And we have microwave antennas, which you can see on the panel on the right there, which are essentially long needles that we can use ultrasound guidance to place into a tumor and burn them with microwave energy. This is the setup we use in the operating room. You can see the operating table in the center of the screen. We have the microwave ablation machine to the left there, and then we have an ultrasound and a video monitor on the other side so that we can see what we're doing. Why do surgeons use ablation? There's actually several reasons. One is, obviously, we can treat patients like we just showed, but also the main issues are that ablation preserves future liver remnant, which is a big problem for patients that have metastatic disease. If you do major resections where you remove 70% of somebody's liver, you really limit their options in the future. So preserving liver remnant becomes very important to these patients. It allows us to treat more extensive disease than we could with resection alone, as I just showed in that previous example, and it can be safely combined with other surgeries. The gestalt of all that is that ablation increases the number of patients that we can treat with surgery with potentially curative intent. Okay. This is just an example of microwave ablation for those of you who have not seen it. This was a 49-year-old patient with an obstructing rectal cancer who had 8 liver metastases. She had a palliative colostomy because she was obstructed, but then received upfront chemotherapy and then underwent laparoscopic low anterior resection along with microwave ablation of 7 lesions and a wedge resection of 1 of the lesions. This is another patient who would not have been able to have any surgical resection because she simply would not have had enough liver left. So I'm going to show one example here. On the upper panel on the left MRI, you can see where my arrow is pointing. There's a hypo-enhancing lesion between these vascular pedicles. And this is the lesion I'm going to show. If we were going to resect this, we would have to do a right hepatectomy and essentially remove 60% of her liver just for that one lesion. And she has 7 others, so obviously not feasible. So in this case, we're going to use microwave ablation, and we're going to be treating this lesion. On the lower left, you can see the actual video camera to show what we're doing, and on the lower right, you can see the ultrasound, which will demonstrate the same. So we'll just get these videos started. These videos are not edited for time, so you'll be able to see how quickly they go. On the lower right ultrasound, you see that there's a hyperechoic lesion. I'll just get my pointer to it. There's a hyperechoic lesion that's going to come in and out of frame here. This is my needle coming along as I guide my needle. And I'm just using the ultrasound to get a feel for where the tumor is, but this hyperechoic area, that is going to be ultimately our target. And as I get closer, you'll see it'll come into frame. So that's our target here. And you'll see I'm just working to get the needle to the target, which takes really just a few seconds or a few minutes in some cases if it's a bit more difficult. But what you'll see here is the needle coming across, slowly advancing to this tumor. And then you'll see that we're going to turn the machine on, and you'll see how quickly that burns. As you can see, there's quite a few vascular structures around here, so obviously you want to be careful about that. The risks of these procedures overall are very low, but if you put a needle through a pedicle, for example, a portal pedicle, you can cause a biliary vascular fistula, for example, or a biloma. So the reason for the pause there for a while was to make sure I wasn't going to hit that portal pedicle just below my needle. Now you've seen I was happy with that placement, so I now have the needle through the tumor, is what you see here, and now we're basically turning on the machine in the background, and in just a minute what you'll see is a burst of microbubbles, which is essentially the microwave is putting off microwave energy just like at home in your kitchen, and it's causing microbubbling of the tissue around it while it essentially heats it up. And it just takes a few moments here, and then we'll move on. There you go. So that's sort of the burst, the initial burst of microbubbling, showing the area we're treating. And actually, these bubbles will ultimately come towards the tip of the needle and surround this area entirely. And in this particular case, if you look at the panel on the upper right, that's the post-operative MRI. And that shows, this is actually several months later. This is our ablation site, which is slowly diminishing in size, but with no evidence of residual tumor. So one of the main reasons we use ablation in cases particularly like this one is because it preserves liver remnant, and it allows us to treat somebody who otherwise would not be a candidate for surgical therapy. This is another similar patient who has a tumor marked with the red arrow here on the MRI. You can see it's deep in the right lobe. And in this case, in order to resect this, it wouldn't be a complete right hepatectomy, but it would essentially be a transection line along where I'm showing with my arrow there, which again is not insignificant. And this is also a patient who had multifocal hepatic metastases and therefore not a candidate for resection. And so it's a very similar, you see the setup is similar. And actually, just to point out for those of you who haven't seen this instrument is actually our ultrasound. So we're able to do these surgeries 96% of the time. We do them laparoscopically and the patients go home the same day. We have a 12 millimeter incision just to allow this ultrasound into the body, and then there's a 5 millimeter incision for the camera, and then just a small stab incision where the needle can be placed through their skin. And in this particular case, on the panel on the lower right, you'll see the ultrasound again, and you see this sort of modeled mixed echogenicity lesion in the center here is the tumor that we're going after. And I'm just, again, making the final adjustments with my needle as we move towards it. And in this case, I won't waste too much time in showing this video again because the procedure is the same as last. But I think what I will point out is in just less than a minute that I've been talking about this particular patient, we already have the needle basically at the doorstep of the tumor. And within 10 minutes, this tumor will be completely treated. So it's also a very quick procedure. One of the other big issues with ablation is, as I said, 96% of the time we can do these laparoscopically as a same-day procedure, even if we're treating 8 lesions in someone's liver. And so this image just compares sort of an old-fashioned surgery where we would make a huge incision to take out parts of the left side of the liver and the right side of the liver and do what seemed like heroic measures at the time. And instead, we can do what's shown on the left, which is basically a few small little incisions and a couple points where a needle goes through your skin and a person goes home the same day. So the other issue with ablation is it has significantly lower morbidity than a lot of the surgeries that would otherwise be necessary. These next few images are really just to show that ablation, when it's performed by a surgeon, can get to any part of the liver. There's no part of the liver that we can't get to in surgery, and there's no part of the liver that we can't get to laparoscopically in surgery. So the purpose of these pictures is just to show different parts of the liver. This one on the upper left, the gallbladder is just off to the right side of this picture. This is duodenum down just below, and you can see we're just getting ready to target a lesion. This would be in segment 5 of the liver. This next one on the upper right is actually up over the dome of the liver. The vena cava is just here under my arrow. We've got an instrument holding the liver down, and we're just freeing up the right triangular ligament so we can get up over the back of the liver under the diaphragm. This is another lesion where this lesion was in the central part of the liver, kind of like the two that I just showed. You can see the ultrasound is here, and the needle is actually going through segment 4B of the liver, which is here, but the target is actually in the posterior liver in segment 7 in this particular image. And then this is another one on the lower right, another way that we get to segment 7. The liver is actually up now. We're looking behind the liver. We've mobilized the whole right lobe. And in this case, we have an instrument holding the liver up. The vena cava is just under here. We have our ultrasound looking up. There's a tumor in the very, very high posterior segment 7. And we have a needle coming from under the liver into that tumor. So anywhere on the right side we can get to, and we can get to it laparoscopically. These are just a few more images showing the same type of thing. Also, the left side of the liver, very easy to get to. We can, segment 3 here, we can put the needle through the falciform. We can take the falciform down. There's all kinds of things we can do. But essentially, there's nowhere that we can't get to. So just to talk about some data, obviously we like to have data when we make decisions on what kind of treatment we're going to use. This is a busy slide, so I'm going to focus on one thing. This was one of our publications from our initial 135 ablations. At this point, we've done over 500 now. But with our initial 135 ablations, one of the big criticisms of ablations historically was a local recurrence rate that was unacceptably high. And the data from that all comes from interventional radiology, where there was a large growth curve when the technology was new, but also they have limitations about anatomic areas they can't treat as aggressively for fear of burning, et cetera. So we reported our first 135 ablations. The per lesion recurrence rate was 4.4%. And when you look at most surgical series, the recurrence rates really should be, when it's done by an experienced surgeon, should be in the neighborhood of about 5%. So essentially very similar to what you would expect for resection. That same study, we looked at overall survival. We had a fairly short follow-up of 28 months for median follow-up. But as you can see, we had an excellent overall survival and disease-free survival, and most notably, those curves do not go to zero. So there are some of these patients that are cured by having microwave ablation. And I also should make one more comment about that trial. The patients included in this series were only patients who were not candidates for surgical resection. So they would have otherwise been getting chemotherapy as a palliative option if they could not have had ablation. And in this case, they were able to have ablation, and many of them enjoyed a fairly good overall survival, and in some cases even cure. We're not the only people that have noticed this. Obviously, this is a study that's now getting a bit old, but in 2017, this was a randomized trial, essentially randomizing patients who had non-resectable metastatic disease, getting randomized to either essentially standard of care chemotherapy versus chemotherapy plus ablation of up to 10 lesions in their liver. It was 119 patients randomized, about 50% to each arm. And I won't go through the entirety of that study, but I will show the most important slide, which is this one. The survival curve of that study was actually quite impressive. And similar to our results, they found that the patients that received ablation of up to 10 lesions had a significantly improved overall survival. And you can see, most importantly, this is a long follow-up, and those curves do not ever come back together. So there are a group of patients here that are cured. We've also looked at the number of lesions we can treat, because right now it's an unknown. When I was in my training, we never operated on anybody that had more than 4 lesions in their liver, and nowadays we do it regularly. So our group has also published our experience with treating 5 or more lesions, admittedly a very small group of patients, but with very acceptable survivals. 2-year survival, 80%, median survival of 3 years, which is significantly better than chemo alone. And 60% of our patients were alive at their last follow-up. The median follow-up fairly short, 2.3 years, but certainly promising. And how many lesions we can treat really remains an unknown. And it, I think in my mind, has to do more with future liver remnant than it does any kind of technical issue. A couple of big trials for people to be aware of that are recent. One is the Maverick trial. This was non-randomized, but essentially was a trial comparing resection versus ablation for small metastatic disease, meaning colorectal mets 3 centimeters or less. I'll give you the highlights, which were that the overall survival was very similar between the groups, but the morbidity of the surgery was less in the ablation group. And the conclusion was essentially that ablation seems to be a viable alternative for small liver mets. More importantly than this, which is now reported, is the collision trial, and this is going to be a game-changing trial for liver surgeons around the world. The collision trial was a very large trial. It initially was intended to accrue 618 patients. They actually stopped the trial early because of the results. This trial randomized patients who had tumors 3 centimeters or less were randomized to resection or ablation. So this is a prospective randomized trial. They ended up having to stop the trial early because the benefits of ablation were so clear. The benefits that they identified are summarized here, but essentially the surgical mortality in the ablation group was 0 versus 2.1%. In the resection group, the length of stay was 4 days versus essentially 0 or an overnight stay. Ablation actually had better local control than resection, which was something that was surprising to most people because that's usually the main criticism of ablation. But in their trial, which was randomized and prospective, ablation actually had better local control than resection. And the overall survival and progression-free survival were identical. So in other words, you get the exact same cancer treatment benefit, but far less of the risk. And so the conclusion of that trial is essentially that if we transition from surgical resection to using thermal ablation, we would be able to reduce complications, shorten hospital stay, improve local control, and we would not compromise survival at all. So moving forward, this is a patient I saw in the past, and actually this is the very first patient that came to me requesting an ablation, and it's actually quite a few years ago now. But this patient's treatment today is far different than it would have been 10 years ago. 10 years ago, we would have done a right hepatectomy in this patient. And just to point out, for those of you who don't look at scans for a living, this is a tumor sitting in the middle of the right lobe of the liver. It's kind of similar to the one I showed earlier for ablation. This would require a right hepatectomy to remove, but it's a very small tumor. It's a solitary tumor. Nowadays, would we resect this? No. Nowadays, this is the type of patient that has a laparoscopic ablation with overall survival outcomes that would be very equivalent to resection, but as a simple same-day procedure that takes less than an hour. So resection and ablation are the only liver-directed therapies that right now are considered potentially curative. We certainly don't cure everybody, but they have the potential to cure metastatic colon and rectal cancers. What else is there? So let's talk about other options for patients with liver metastases from colon and rectal cancers. Many people have heard about a new technology called histotripsy. The company is called Histosonics. This slide was given to me by my colleague, David Brower. We were actually part of one of the first trials for this device called Hope for Liver. Essentially, they enrolled a small number of patients treating on average 1.5 centimeter tumors. We actually screened 30 patients for this trial and were not able to enroll any, so we were not included on the publication. And that's because the criteria were so strict that we were not able to identify anybody who was unfortunately a candidate for that trial. The original or the initial publication that they have now reported essentially had a 30-day efficacy of 83%. So it is certainly a promising technology and a very interesting technology, but it's really not ready for prime time. 30-day efficacy, meaning a 30-day complete treatment response rate of only 83% is certainly not as good as what we can do with other current modalities, including resection or ablation. So definitely something we're looking at. I think something that will get better with time, but something that is not quite ready for prime time at this point. Another option is catheter-based therapies, and this is something that does get discussed quite a bit, and I think it's important that we talk about it, even though it's not a surgical procedure. Y90 is by far the most common one that we discuss, and what Y90 is essentially, another term for it is SIRT, or selective internal radiation therapy, and it's essentially a procedure where they put a catheter through a major vein in your body, either through your leg or through a major artery in your body, either your groin or sometimes through the wrist, where they place a catheter up through the aorta into the hepatic arteries, and they identify the blood flow to the tumor in your liver, and then they treat it by injecting microspheres that can be made of resin or glass that essentially give off radiation. But they give off the radiation in a very localized area where the beads are delivered. So what's the utility of Y90 for treating metastatic colon and rectal cancers? There's actually 3 randomized trials. There's actually more than that, but there are 3 main randomized trials now with over 1,000 patients that have been reported, and they all have the same essential setup, which is chemotherapy alone as palliative treatment for these patients versus chemotherapy plus Y90. This slide is very busy, but it essentially lists the 3 main trials that were called Foxfire, Surflox, and Foxfire Global, and all of them came to the same conclusions separately. But this report is a report combining all of them as a meta-analysis. And essentially, like I said, it's over 1,000 patients that looked at chemotherapy versus chemotherapy plus Y90. And the upper 2 panels on this slide show the results of the meta-analysis, which essentially, if you look at overall survival on the top left here, you can see those curves are completely overlapping. So FOLFOX, the standard chemotherapy alone, is the blue line, and FOLFOX plus Y90 is the red line, and they're completely overlapping. So no improvement in overall survival. Progression-free survival is one of the things that had been sort of thought to be a potential benefit of Y90. You can see on the panel on the right upper, again, the blue line is chemotherapy alone, and the red line is chemotherapy plus Y90, and again, you can see completely overlapping. So the reality right now is that Y90 is really not an appropriate first treatment for metastatic colon cancers and not something that we use often. There are sometimes very specific cases where it might make sense, but as a general rule, we should not be using Y90 as a treatment for metastatic colon and rectal cancers. Getting closer to the finish, hepatic artery infusion pump is a emerging and growing option for patients who have non-resectable metastatic disease in their liver. Hepatic artery infusion pumps have actually been around for a long, long time, several decades. They were actually invented here at the University of Minnesota by Dr. Henry Buchwald in his lab. But their utility has gone in and out of favor. And 20 years ago, they were used regularly because the systemic chemotherapies for this disease really weren't great. But as systemic therapies got better, the benefits of adding a hepatic artery infusion pump were diminished by that. But what has happened over time with the leadership of places like Memorial Sloan Kettering in New York, who's really probably the busiest and well-known center of excellence for this, they've really started to identify which patients might actually benefit and how we can use hepatic artery infusion pumps more thoughtfully as part of a care plan. The way that this works is essentially, and I should mention that these slides are courtesy of my partner, Dr. David Brower, who runs our hepatic artery infusion pump program. The way that hepatic artery infusion pumps work is essentially we insert a pump into the abdominal wall under the skin, and there's a catheter that goes through the abdominal wall, and we essentially place it into the gastroduodenal artery so that it can slowly infuse chemotherapy into the hepatic artery and deliver high-dose chemotherapy that's directed at the liver. We also free up small blood vessels to make sure that the chemotherapy is not going to any unintended destinations. The pump is about the diameter of a hockey puck, but a little bit thinner than that. So modern hepatic arterial infusion pump therapy falls into sort of two categories. One is for patients that have unresectable disease, not a candidate for surgery, but can we prolong their life by adding a hepatic artery infusion pump? The second category of patients are patients where we wonder, does it make sense to use a pump as adjuvant therapy? For example, some of those patients I showed earlier that have multifocal bilobar disease in their liver, their overall risk of hepatic recurrence is high. It's very high. And so should we consider putting pumps in those patients to improve their chances of overall survival or disease-free survival? So we'll start with the first one. The goal of putting pumps in patients that have unresectable disease, one is to extend their life. The other is, can we get them to resection? And this is a nice study. It's about 6 years old now, but 64 patients with a median of 13 tumors, unresectable. On the right upper, you see a panel with dark-colored and light-colored lines. The dark-colored lines are patients that have had previous systemic treatment, and this is showing the amount of response, essentially. The light-colored lines are patients who are treatment naive. So patients with prior treatment in this study had a 67% reduction in their tumor burden, which is fairly significant, I would say. Patients with no prior treatment, 73% reduction. So hepatic artery infusion pump can lead to substantial response rates that you don't necessarily see with systemic therapy, and even in patients who fail systemic therapy, this can often add to that. Maybe the most important thing about this trial was that over 50% of the patients who were initially non-resectable were converted to resectability. And that's important because I already mentioned earlier, the only way to cure this cancer or to have the chance of curing it is with surgical resection or ablation. So if you can get patients to resection, that makes a big difference. And actually this next panel shows that. So the lower right here shows the difference in survival between patients who were not able to get surgical resection, which is the solid line, compared to the patients that were converted to resectability, a much, much better survival, which is not entirely surprising, but a significant number of patients. So hepatic artery infusion pumps can induce response even in pre-treated patients, and it can convert patients who are currently unresectable to resectable. And if we can get patients to resectable and we can resect their tumors, their survival is significantly improved. What if we use it for adjuvant therapy? I won't go into the full details of this, but there was a retrospective study a few years ago in the JCO, about 2,400 patients who were resected and then had an adjuvant pump placed. And the summary of it is the pump does seem to improve chances for overall survival, 44 months versus 67 months for pump patients. One of the difficulties in this is that we don't know who is most likely to benefit. And so that is one of those things that only the future will tell. So where are we now? There are a lot of centers across the country that do pump placements. Some of them are listed here. Obviously, the most important one is us. The pump was designed here and is now enjoying a resurgence here as well. So finally, I'd like to talk about one last topic, which is transplantation, liver transplantation for colorectal liver mets. And I'm not going to go into a lot of details given the overall length of time of this talk. But there is a recent trial that has been published now last year called the TransMet trial in France, led by René Adam, who's a very world-renowned liver surgeon. This was a randomized trial. 94 patients were randomized to chemotherapy or chemotherapy plus liver transplantation. And this panel really summarizes it all. The upper right here, you can see the survival curves. For patients, the blue line is patients who got chemotherapy alone. The red line is patients who got chemotherapy plus liver transplant. So again, similar to some of the other therapies that I've shown, surgical resection, in this case, sort of the ultimate surgical resection of removing the entire liver, does seem to have the ability to at least offer the possibility of cure or certainly long-term survival. Progression-free survival wasn't quite as promising, but certainly seemed better than chemotherapy alone. So again, the chemotherapy alone is the blue line. The red line is chemotherapy plus liver transplantation. And so some of these patients certainly do recur, but their overall survival is clearly improved, as is their progression-free survival. These were the eligibility criteria for that trial. So these patients all had to be unresectable with sort of standard resections. They had to have stable disease for at least 3 months. So you can't have patients that are progressing on treatment and then go on to transplant. The outcomes for those patients, obviously not good. They have to be BRAF wild type because those patients do tend to have a bit better prognosis. And they have to have a reasonable CEA of less than 80. In addition, all these patients had to have their primary tumor resected. So there is definitely some promising data for liver transplantation. Obviously, a lot of limitations of transplantation also because of the fact that we have an organ shortage. It's not as though everyone can get a liver transplant who needs one. And so there is a lot of debate because some of those other issues that revolve around this. But it is certainly a viable option in properly selected patients. So this is just a unofficial treatment algorithm that I put together to sort of help think through the process of how do we make decisions for how to treat these patients, because we do have a lot of options, and the type of patients we see is really widely variable. The size of the tumor, the number of the tumor, the timing of when they got it, the factors involving their primary tumor. There's a bit to that decision making, but this is intended, I hope, to simplify it, although there's going to be a lot of lines on it, you'll see. So if we look at all the patients that we see with liver metastases, the very first sort of simple thing is to make sure they have liver-only disease. If they have disease outside of their liver, those we have to be very thoughtful as to whether surgical resection is going to provide a benefit. And the main reason is if you have systemic disease throughout your body, a local therapy like surgery for your liver is not likely to cure that problem. So the main people we're going to focus on, particularly for this talk, is patients who have liver-only disease. Patients with for full disclosure, when there are patients with disease outside their liver, in rare cases we will still operate on them, but that's a bit outside of the scope of the discussion today. So patients with liver-only disease, the next thing is it a single lesion or is it more than one? If it's a single lesion, how big is it? Is it bigger than 3 centimeters? If it's bigger than 3 centimeters, we will typically resect it. And the reason for that is really all of the existing data for ablation is that the risk of a local failure or a local recurrence begins to go up when tumors get larger than 3 centimeters. And that's just a limitation of the technology. The truth behind it is we can burn lesions larger than that, but as I said, the recurrence rate starts to go up. So generally the cutoff that we've accepted is 3 centimeters for that. So if tumors are bigger than 3 centimeters, we definitely favor resection. For solitary tumors that are less than 3 centimeters, nowadays, ablation is the way that we prefer to treat those for all the reasons we discussed previously. For patients that have multifocal disease, it's a bit different because the size is not necessarily the issue, actually. The issue becomes, can you treat all the lesions or not? And that's really the big game here. Whether the tumors are larger than 3 centimeters or smaller, the question is, can we treat them and still leave enough liver in a person's body so that they can function, have a normal life, et cetera? So if they are all resectable or ablatable or a combination of both, that's what they get. They get surgical treatment. If they're not all treatable, we don't ever do debulking or cytoreduction in this setting. We don't treat 3 lesions and leave 2 others. That's not something we do unless we have a plan to stage that resection and take them out at a second operation. So in general, if somebody has lesions in their liver and we can't remove them all, they go to primarily systemic chemotherapy. And I should also mention, by the way, systemic chemotherapy is often used before any liver-directed surgery early on in this decision-making process as well. But there is a bit more debate nowadays as to the utility of upfront chemotherapy, again, a little bit outside of today's discussion. But certainly if someone has a non-resectable tumor burden in their liver, systemic chemotherapy is going to be the next step in their treatment. And then depending on how that goes over time, they may become candidates for a hepatic artery infusion pump or liver transplant. And there is actually some overlap between these because it's a very similar patient population that are candidates for both of these options. And so those are sort of next line therapies for patients that have chemotherapy, who have disease control on their chemotherapy, who do not develop any extrahepatic disease in their body. And that's how we sort of decide who might be a candidate for hepatic artery infusion pump. Like I said earlier, the other decision-making factor is, do we think we could get them to resectability? And if that's the case, that's when we start thinking about hepatic artery infusion pumps. If they have extrahepatic disease, like I said, for the most part, those patients are going to have systemic chemotherapy alone. Future question, which we're, I think, moving towards, is for those patients that do have multifocal disease, after resection and or ablation, should we be placing pumps as adjuvant therapy? And that is a discussion that continues to evolve. One of the main things for everyone to know also is that surgeons should be involved in this process early on. So surgeons can help make decisions for which treatment option is chosen and how we work through this process. The main reason for that being that it's challenging sometimes when a person has metastatic disease, gets placed on systemic chemotherapy, and then a year goes by where they're getting chemotherapy for a year, and only then somebody, the medical oncologist says, well, gee, maybe we should have the surgeon see you. The challenge in that situation is now they've had chemotherapy for a year, and chemotoxicity is a real problem. And so patients that are receiving oxaliplatin or irinotecan will often have, unfortunately, evidence of hepatotoxicity from their chemotherapies, even if you give them more than essentially 12 cycles of chemotherapy or 6 months, and in many cases less than that. So it's very important that surgeons are involved in this process and in this discussion early on so you can tailor the right treatment plan for each individual patient. With that, I will say thank you very much, and I hope you enjoyed the lecture.